clap for my marker. Welcome back. This is Andre Koen with another episode of Speaking of Diversity and Inclusion at the Mayo Clinic. Just want to remind folks that this is our inaugural season of Speaking of, and so as things strike you as interesting, or there are things that you don't like, maybe it's the soundtrack, or maybe it's one of our guests that you would like to have back and have more conversations with, please communicate with us as we begin these sessions. So we hope that you enjoy these and that we bring you some folks that can really spark your thinking about the importance of diversity and inclusion here at the Mayo Clinic. And so today I have an old friend, and we haven't seen each other in a long time, and I really appreciate him taking the time to talk with us. Dr. Jason Purnell of the Brown School of, let's do that again. 1, 2, 3. Today we have Dr. Jason Purnell of the Brown School. No, say it for me again, Jason.
The Brown School at Washington University in St. Louis.
That's what I missed. Okay. All right, here we go. And today we have Dr. Jason Purnell of the Brown School at Washington University in St. Louis, Missouri. So Jason, can you tell us a little bit about yourself, how you got to the Brown School? We're curious.
So I have been at the Brown School for almost a decade now. It was 9 years ago in September. I'm actually a psychologist by training. I tell people I'm a psychologist in a school of social work who does public health. So a bit of an identity crisis some days, but I got interested in health disparities after graduate studies with a clinical psychologist named Barbara Anderson, who was doing work on psychological adjustment to breast cancer. And I got interested in cancer disparities and then larger disparities beyond just cancer. Followed up my PhD with a postdoc in cancer prevention and control, and then got my master's in public health along the way. And I've been interested in health equity and social determinants of health ever since.
Wow, wow. Now, what I do know is that you also, I mean, in your early 20s, you also started a nonprofit. Is that correct?
It's an initiative of the Brown School called Health Equity Works. We started with a report that was released in May of 2014. That was a collaborative effort with faculty members at St. Louis University and Washington University, a report called For the Sake of All, which was on the health and well-being of African Americans, looking at health equity through a social determinants of health lens, and then making recommendations about how we could better address community health in the St. Louis region.
Now, okay, so we're here at the Mayo, and we have lots of cutting edge opportunities to help folks to bring new technologies, new procedures, particularly to either underserved or people who've just not been a part of our opportunities to serve, so we can actually really help people. But one of the things that we're finding is that particularly, let's use one group, African Americans. We're finding that African Americans are less likely to be a part of our clinical trials, right? So this is really cutting edge stuff. What do you think contributes to African Americans being less likely to do that? And what might be some things we could do organizationally to encourage that?
I think the issue is likely bidirectional. there's probably a fair amount of distrust and mistrust of medical research given the history and the present day discrimination that African Americans face in medical settings. So it's not just an awareness of things like the Tuskegee trials, but it's people who are interacting in medical settings currently and not feeling respected, not feeling listened to. So I think there's probably a fair amount of distrust on the patient side. And then the systems and the infrastructure within academic medical settings could probably be improved so that there is greater outreach and actual embeddedness within community, rather than just hanging up a flyer or putting out an ad saying be part of my clinical trial, establishing real relationships with communities, and having the opportunity to build that trust and letting people understand what the benefits of this research is. I think communities have become understandably and justifiably jaded because they've seen researchers come into their communities, collect data, leave, never tell them what the results were, and never explain or attempt to provide benefits based on that research. Yeah. So I think there's work to be done on both ends.
So how do we do that? Because, I mean, that's part of what research is, right? I mean, you take the data, you take the information, you use it to, further the financial resources, or you quantify that so that the researching institution can monetarily benefit from that. I mean, isn't that just like the natural process of the engagement?
I think it's what is currently thought of as the natural process. But if you want to increase diversity and inclusion within those study populations or study samples, you're going to have to create long-term relationships with communities that aren't just about swooping in, getting the data, and swooping back out.
So what have you seen this, I mean, in the St. Louis area? I used to work with a group called the Caring Communities, which was kind of this grassroots, holistic approach to educating both community and people and all sorts of stuff. I'm not even sure if the Caring Communities are still around in St. Louis, but I do know that there was a lot of work dedicated to making sure that people had access to good quality healthcare. And so what have you found has been effective in making sure that that folks have access to healthcare there in the St. Louis area?
Well, the most critical thing has been increasing access by making sure that people have coverage. So the Regional Health Commission has been a crucial partner in the St. Louis region, making sure that in the absence of Medicaid expansion in the state of Missouri, Missouri is one of the states that has not expanded Medicaid. There is a program that the Regional Health Commission was able to negotiate with the federal government to provide access. It's called Gateway to Better Health. So that is an example, I think a very powerful example of the academic medical centers, the federally qualified health centers, and the major health systems in the St. Louis region coming together around the table of the Regional Health Commission. And that Regional Health Commission is constantly collecting data, reporting that out, partnering with others in multiple sectors in the St. Louis region. And we've seen really powerful organizations and entities kind of spin off from the Regional Health Commission, like the Integrated Health Network, which is kind of a common table for safety net providers. Alive and Well, which is now its own freestanding organization focused on trauma and toxic stress throughout the state of Missouri now. That started as a Regional Health Commission initiative. So where we have seen successes in those efforts to work across sector, one of the things we're doing that we've been very involved in is providing school-based health centers for the St. Louis region, and now for the state of Missouri. That came out of a work group that For the Sake of All established and initiated around school-based health centers, sort of the optimal model being, one of the optimal models being an on-site full-service health clinic, health center within the school setting. And that, again, is a collaboration that cuts across the education sector, healthcare sector, nonprofit spaces, to make sure that that access point is available for young people.
So did folks just come around the table because they saw this void in the community and said, you know, let's put our best minds together and try to figure out ways to close this gap? Or what was the impetus for these folks kind of coming around the table to create these school-based health centers?
After we released the report in 2014 with support from the Missouri Foundation for Health, we were able to pivot to a second phase where we took the areas of recommendation. So there were 6 major areas of recommendation, and school health was one of them, for addressing health equity in the St. Louis region. And the community really demanded that there be more than just recommendations, that there be action taken. So we, along with our partners at the Institute for Public Health at Washington University and Forward Through Ferguson, which was, you know, you've got to put this work into the context of Ferguson. So we released that report on May 30th of 2014, and Michael Brown is shot and killed on August 9th of 2014. So the report becomes one of the sources that people in St. Louis and around the country and around the world are turning to try and understand the source of their frustration, the depth of the disparities that exist in St. Louis. So that's part of the impetus, that there's this energy that we must respond to the events of Ferguson, but also this report presented disparities in a stark and compelling way, and there were multiple actors across sectors who were really motivated to come together and plan for what the action ought to be. So school-based health centers was one of those areas through this convening that we co-hosted, where a group of stakeholders came together and stayed at the table. And I give lots of people great credit for that, including our partners at BJC Healthcare, which is the largest healthcare system in the St. Louis region, but also the school districts that were involved, the nonprofit organizations, the community health centers, the federally qualified health centers, all staying around that table.
That is really profound, and I think given what people think they know about Ferguson and what they think they know about Michael Brown or whatnot, I think being able to link some of those, some of the systems that created the atmosphere where folks felt like they needed to demonstrate in some ways that other folks may, they may use other words for that, but folks demonstrated that they weren't happy with the living and life conditions, particularly when they saw the life of Michael Brown taken by police. I think the way the community responded to that has been pretty dynamic. Even for those of us who don't live directly in the St. Louis metro area, which Ferguson is a part of.
Right.
So you mentioned a couple of things. I'm going to come back to some things that you just mentioned. One is this idea of toxic stress, right? So how should we be thinking about toxic stress? Like, why is that important? We all experience stress. So what makes stress toxic?
I think part of what makes stress toxic is the inability to escape some of the environments in which the stress is being presented. So I mentioned earlier that I'm a psychologist, and I think about in my training treating veterans returning from war zones for post-traumatic stress disorder. Part of the way that you go about approaching that treatment, at least the state of the art a decade ago, was some cognitive restructuring, cognitive reframing, helping those veterans to understand that they were in a war zone, but now they're back home. And the response that was adaptive in the war zone is no longer adaptive back home. But we have children and families who never leave the war zone, for whom the stress response is always going, chronically going, and can't escape the multiple stressors that they're facing. And we know from the scientific literature the kind of wear and tear that has on the body, and the ways in which that ends up sort of getting under the skin and creating all kinds of disease states and early death and disability.
So are you suggesting that toxic stress toxic stress could be a contributing factor to, kind of the low birth rate, or the low birth weight rather, of African American children, regardless of socioeconomic status?
That is certainly one of the hypotheses. There was an entire episode of the PBS special a few years back now called "When the Bow Breaks" as part of Unnatural Causes, that talked about low birth weight among even high SES African American women. They followed a woman who was a lawyer, I believe, who had taken all her prenatal vitamins. She was eating healthy. She was exercising. She still delivered a baby at low birth weight. And we reported on that in the For the Sake of All report, that an African American woman with college or more education is still more likely to deliver a baby at low birth weight than a white woman who hasn't graduated from college, or hasn't graduated from high school rather. So the stress that's associated with racism is still a very potent factor in predicting African American health outcomes. It might seem counterintuitive because we're used to thinking about socioeconomic status as the great equalizer. But even at high levels of socioeconomic status, African Americans, for instance, are more likely to be encountering people outside of their racial group in their daily lives, and the stress that's associated with whether it's microaggressions or large-scale discrimination on a daily basis translates into a stress response. Now, that's not the only explanation for low birth weights.
Right. I was just trying to draw that conclusion back to this toxic stress as a contributor. Now, you just used a word that I'm not sure that everyone is necessarily familiar with, and you said microaggressions. So what are microaggressions, and how do they relate to toxic stress? I mean, that's what we're talking about.
Microaggressions are conceptualized as the sort of daily interactions that people who are members of oppressed groups experience that do have that sort of they have distress and agitation and stress attached to them. They may not be something as dramatic as hate speech or employment discrimination, but they are things like being questioned in terms of your the appropriateness of your being in a particular setting, or your being singled out because of some identity that you hold, and these kind of smaller experiences add up to create a stress response.
So, the classic things like being followed in the store, or having your ID checked when other people don't have their ID checked, are those small things you can't, really sue over, right? You can't go to HR and say, they were looking at me.
Right.
But they do have a sum total impact on an individual's psyche. Well, thank you for clarifying that. I appreciate that. I was also thinking about this idea of this kind of cognitive behavior therapy piece you were talking about. You're working with, you're talking about veterans coming back from combat, and really trying to get them to think about themselves. In this diversity, equity, and inclusion space, how much of that should be done by the people in responding to those stressors, that toxic stress, by the people impacted by it, and how much should that cognitive behavioral therapy, really talking about how you think about people, how you interact with people, should be done on the part of the service provider themselves?
I think there's definitely an opportunity, and I think there are growing opportunities across multiple sectors to be more trauma informed in the approaches that service providers are undertaking. I don't think that the onus is on the individual who's experiencing those stressors. I think, a lot of the conversation in the trauma space has been about changing the question from what's wrong with you to what happened. And I think that's critical. We think about that in terms of our work with schools and in school health. And it's really a paradigm shift for the helping professions to have that broader contextual understanding that, for instance, a child who's acting out in school may have experienced something the night before on the way to school that is a better explanation for their behavior. But there's something interesting in psychology. We call it the fundamental attribution error. This notion that kind of the lighthearted example is that if you're 15 minutes late for an appointment, I'm going to blame you and some flaw in your character. But if I'm 15 minutes late for the same appointment, I'm going to explain that away as the kid's bus didn't come on time, I didn't sleep well last night, the car wouldn't start. So we give ourselves a lot of situational excuses and explanations for our behavior, but we interpret other people's behavior as some moral failing or character flaw. I think that is, I think that's a hurdle for us as humans, but it gets magnified when we're talking about traditionally marginalized and socially disadvantaged populations, where there really is a tendency to blame people for their situation rather than understanding the broader context.
So how do we get over that hurdle? I mean, you said it's a human tendency that I know that in our space here, there's been some conversation about this idea of stereotype threat and unconscious bias. How do we get over that hurdle of saying that you have a moral character flaw, but for me, I'm just running like things happen to me, right? So how do we get over that hurdle, or what suggestions do you have?
I think we need a new narrative. Just as we came to understand and this, of course, is interesting and tied up with issues of race and diversity as well. But, we have an opioid epidemic now.
Mm-hmm.
And the current conversation is around addiction and the kinds of treatments and prevention that are necessary to address addiction, which many commentators have pointed out is a starkly different conversation from when crack cocaine was introduced into communities of color. But that understanding, that evolution of an understanding of addiction and the ways in which substances impact the body is an example of a narrative that has changed. We're not just blaming people for a lack of willpower or a lack of moral rectitude. We're recognizing that people are impacted in multiple ways by substances. The analogy that I've used is, and I don't know if this is a uniquely American phenomenon, but I suspect there's something in our history and culture and character that leads to this notion that just rugged individualism alone explains life outcomes.
Mm-hmm.
And the analogy that I use is water and ice. So you can't get ice without freezing temperatures. And it doesn't matter how great the water is. It can be the most pure water in the world. It won't become ice unless the temperatures are 32 degrees Fahrenheit or lower. And it turns out, I did a little research on the chemistry and the physics of water and ice, and water that's under pressure actually needs colder temperatures to turn into ice. So in my mind, water is like individual effort. It's absolutely necessary, but it's not sufficient for ice. You don't get to ice without freezing temperatures, and freezing temperatures are those factors in the social context that allow people to flourish and succeed. They are those social determinants like adequate housing, income, quality education, supportive and safe neighborhoods with services and amenities. But we very often blame people